So the cardiac patient or patient with cardiac disease for non-cardiac surgery. Now, just to give you a bit of perspective, this is something I learned in my advanced training years, which is, 3 to 4 years after starting anesthesia. And it's something that I wish I'd learned in day one because I use it every single day. And I'm hoping I'm gonna blow your minds a little bit with this. This is all based on the ACC AHA guidelines. So if you want the absolute gold standard of what to do in cardiac situations, the American College of Cardiology and the American Heart Association have a whole bunch of free guidelines. Just Google whatever guideline you want. And the stuff that they publish is what the whole world decides is right. So, and just to know that that's a really great thing to know, right? So, if you quote guidelines, which are very easy and very, manageable to read like this one, I'll show you how to simplify this particular very detailed guideline. It means that you're taking the knowledge of the experts of the world who've come up with these consensus decisions. So, I've got my opinion, you've got your opinion, the next consultant has their opinion, but, my opinion matters very little when it comes to some really strong evidence from experts who know the stuff far better than I do. And so that's why I think the relevance of these guidelines and for yourselves, knowing where to find these guidelines is really important. So take home points already. ACC AHA is the gold standard for cardiac stuff, valves, dual antiplatelet therapy, atrial fibrillation management. You could literally Google this and know as much as any consultant anaesthetist and hopefully be able to show that and use that for your patient's care. Now, the part of this that I'm going to focus on is this really complicated flowchart. I really like that someone mentioned greater than 10 METs previously, because that's actually the number that shows that you can proceed to surgery with class 2A evidence that the patient's going to be overall okay, regardless of how bad their heart is, as long as they're not having a heart attack right there and then. So anyway, to move on, we're going to take this guideline, which is a step-by-step way of going through whether you can have surgery and proceed or postpone and optimize the patient, because that will be one of the most difficult decisions you'll face every day with every patient. So my simple approach is this: every anaesthetist really loves morning coffee. I was really proud of this because I made this up myself, and it really suits the anesthesia field because that seems to be all we really worry about, having a coffee break, make sure everyone gets around our coffees, and that's just how we roll. So every anaesthetist really loves morning coffee stands for emergency, active cardiac condition, risk level, is it low, greater than 4 METs, and will testing change management, so C for change or cardiac testing, or continue with surgery. And obviously can't hear you, but I want everyone to say every anaesthetist really loves morning coffee just out loud, and you'll end up using this every day. Trust me on this. And I'm just so sad that it took me so long in my training before someone told me that this existed. So this is my gift to you today. So emergency surgery, there's no time for thorough evaluation and management. So this is quite obvious. You optimize the patient as best as you can, but you can't really refer them to cardiology or send them for testing because they have a AAA that's going to kill them right there. So you optimize as best you can, you increase your monitoring and crack on as best as you can. So that's emergency. If it's emergency surgery, there's no real decision that you need to make except make him as good as you can and crack on. The next one, A, so every anaesthetist, A for active cardiac conditions. If the patient has any of these, then so now it's elective surgery, E for elective. So I move down, is an active cardiac condition. If it is active and not an elective operation, I'm well within my rights to refer this patient and postpone. So these active cardiac conditions are recent MI, and they've judged as 60 days in this guideline, unstable or severe angina, decompensated heart failure, severe valve disease, the stuff that kills you as severe AS or symptomatic MS, then significant arrhythmias, all the really bad slow stuff, all the really bad fast stuff, or uncontrolled stuff. If that's active, I then postpone and refer. So that's every anaesthetist really loves. So what's the risk level? Is it low? So generally speaking, there's 2 ways that I decide on risk. If the surgery is just so minimally invasive, like scopes, endoscopy, gastroscopes, colonoscopies, cystoscopies. If it's cataract operations, really superficial surgery, breast lumps, skin lesion excisions that just need a bit of local anesthetic, any kind of ambulatory surgery, that's almost always going to be low risk surgery. So imagine this situation: you've got a patient who's having an elective operation, doesn't have an active cardiac condition, and they've got low risk surgery, you can just crack on. There's some really big series of patients having low risk surgery, even with decent heart disease. As long as it's not active, they can have the surgery with very minimal risk. If I'm not sure about the perioperative risks, you could use the risk calculator, and they suggest that risk level less than 1% is low risk surgery. Practically speaking, I just use this surgical classification of low risk to proceed. I don't necessarily use the risk calculator for this, okay? But then it's, again, something you can discuss with your consultant, and again, show your knowledge, show your ability to gather information that adds value to the situation. Finally, metabolic equivalence. I've gone through this in more detail in one of the YouTube videos on assessment. But yeah, it's what you've said. It's the metabolic work that someone can achieve. So they take the amount of energy sitting, or the amount of oxygen requirement, which is 3.5 mils of oxygen per kilo per hour. It's roughly 250 mils per minute. Again, in a 70 kilo, 40-year-old male sitting quietly. And then it's multiples of that. So there's this index called the Duke Activity Status Index, and it's really quite remarkable. If you Google it, they've done the metabolic equivalence for so many different activities, whether it's walking or playing singles tennis versus doubles tennis. They've done the studies on it. So 4 METs is the amount that seems to correspond with better survival postoperatively. Is one quite large study that showed that if someone could do greater than 4 METs, they had less perioperative morbidity mortality. What's interesting is that often we ask this question, can you walk up 2 flights of stairs? And that was a separate study that didn't really refer to METs. They just had patients climb 2 flights of stairs, and they got really specific. Like this is pretty interesting stuff. So 20 steps, 6 inches per step roughly was what each flight was. And they had to be able to climb that without stopping, or they had to walk 4 blocks of a certain distance. And if they couldn't do that, that was they had increased risk of perioperative morbidity and mortality. And this correlates well with perioperative survival. So just to know that when I'm asking these questions, really, I'm trying to figure out whether they can do 4 METs. And if you think about it, this is a very low bar. Almost anyone can do 4 METs. And sometimes I feel almost strange asking the question, but as a habit to create, just ask everyone what's the most activity they can do, just to get an idea of what different patients can do. And just know, it's probably worthwhile mentioning, the reason that anesthesia is very safe. Most of the mortality and morbidity of anesthesia is in the post-operative period. If I can't do more than 1 MET, which is just sitting there, what are the chances that my body can mobilize, oxygen and nutrition through heart and lung function to deal with complications or heal a big operative wound? Or deal with complications like, DVT or infections. So the fact that you can do more than, 4 METs means that my heart and lungs can, I can breathe faster, I can generate tachycardia to sustain the healing process and manage complications post-operatively. That's really what this METs is about. Moving on, will testing change management? So I've gone, is this emergency surgery? No, it's elective, great. Do they have an active cardiac condition? No. Is it low risk surgery? If it is, I can go straight ahead and do the operation. If it's not low risk, can they do enough metabolic equivalence? If they can do more than 4 METs, crack on with surgery. If they can't do more than 4 METs, so that they're pretty much bedbound or something, will testing change management? And by and large, most of the time these days, it means that it's yes. If you somehow do some kind of stress test and the patient has cardiac disease, often you can, for an elective operation, you can dilate that vessel, put a stent in. That's a very low risk procedure, and then wait for 6 months to a year to do the operation. It's a nuanced discussion, a lot of consent issues, and finding out what the patient's needs are. But that's how you'd approach the situation. Very few patients would say, "I don't care if you test me and I've got major heart disease. I don't want surgery." Very few patients will say that. So you're always safer, especially as a junior, to opt for testing rather than not testing, according to this guideline. Well, the best way of learning this stuff, obviously, is let's go through some exercises. I'll just put that up quickly, but we know that we can do a lot of things with minimally invasive surgery to make things work. So let's go with this. 68-year-old patient, non-STEMI 2 weeks prior, and ongoing unstable angina. They really strangely had a high-speed MVA, free fluid in the abdomen, and the surgeon wants to proceed to theatre urgently. So I want you to now take 30 seconds for this one. think about what you need to do according to the guideline?
Yeah, so this patient has active ischemic heart disease, unfortunately, but they also have an emergency indication for surgery, so we just have to proceed.
Exactly right. So pretty easy. It's emergency surgery. They're going to die without an operation, so they need to proceed regardless. The level of evidence is 1A, so it's expert consensus, but there's very little evidence for it because there's just so much common sense for that. But it doesn't mean that I can't do anything. It means that I just have to optimize everything. So to supersize my management, art line, maybe a central line, I transfuse the patient to the right HB level, promote oxygen delivery, and maybe try to get that oxygen supply-demand balance right by avoiding any unnecessary tachycardias with good analgesia and maybe small dose of beta blocker as I'm going through, and looking for ischemia on the ECG or echo and treating with whatever management I have. You might want to add aspirin down a nasogastric tube or something like that in this case. But that's good. Emergency, proceed. How about this one? 78-year-old female, fractured knoth, multiple comorbidities, currently in pain, signs of fluid overload, mentally alert. Again, going through your system. Do you proceed or postpone? Take 30 seconds for this one.
For this patient, we thought that the surgery was urgent, but not necessarily emergent. We probably had like 24 to 48 hours at least to assess and optimize. So
yes.
I guess in this we would refer, discuss with cardiology and optimize as much as we can within the next whatever time frame that we have.
Fantastic. So I like the fact that you called it urgent. So the emergency category has all levels of emergent to urgent to time sensitive. And this one falls in the emergent category. And you mentioned optimize. What could you optimize in this patient in the next 24 hours that you could do?
So I guess in particular, if we're worried about her heart, she's already in pain. So we would obviously do a regional block and make sure that we have her analgesia optimized to prevent tachycardia. We could optimize the fluid status, probably with some diuresis before the surgery. And
perfect. That's really good. So the things you can optimize in a short time frame, they're not things like revascularization of a tight left anterior descending. It's things like optimizing heart failure with diuretics, like you mentioned. So often the things you'll see in this circumstance are rapid AF in these patients, unstable CCF, severe sepsis due to pneumonia that brewed during their fall and their stay in hospital, or maybe they've had a HB drop due to existing anemia plus some blood loss as well. And those are all things that you can treat, at least stabilize, optimize to a certain extent in a short time frame. So you'd almost always crack on within that 24 hours or 48 hours if you had theater space. That's really good. Next one, 70-year-old male, PR bleeding, secondary to colon carcinoma. A lot of stuff going on there, unknown exercise tolerance. Again, take 30 seconds, and I'll ask Lauren at the end of 30 seconds what you want to do. Okay, what do you reckon, Lauren?
Hi. So 77-year-old man who requires a semi-urgent surgery for cancer surgery with active PR bleeding. So he doesn't have any evidence of any active cardiac conditions currently, but we need to further assess his risks with the RCRI calculator to sort of know where to go next.
Yep.
And assess his exercise tolerance. So those would be my next steps.
What do you reckon, Lauren? Do you reckon, what's the urgency level of this surgery?
It needs to happen fairly quickly. I mean, he's got malignancy causing bleeding. So I'd put it in the urgent category.
Yeah. So it's almost like, and again, this is a nuanced area and you'd have a discussion with the surgeons about all the detail, but you wouldn't want to delay more than a couple of weeks in general for these cases. So it still falls in the emergency category. So you'd have a discussion about what kind of heart disease they might have. But, if you couldn't get the stress echo, if you couldn't get the angiogram, if you knew that you weren't going to do anything like a stent with the angiogram, that's all the discussion you can have. What could you do to optimize in 2 weeks with the resources I have? And it can get very complicated, but just to know that that's the discussion you have. And it still falls under now the time sensitive, but still emergency category in the guidelines. So I don't need to necessarily think about all the other things. Okay, these are all emergency, urgent, or time-sensitive operations. They need a nuanced discussion, but just to alert you the fact that they fall under the emergency section of that guideline. Let's keep going. So you've got this patient, a 60-year-old lady for lap chole, chronic atrial fibrillation, now with a rate of 140, but no symptoms.
Hi. So it doesn't seem to be an emergency surgery. It's an elective surgery.
Yes.
And given that she has an arrhythmia with AF, that's rapid, you want to refer her.
Absolutely.
And delay the surgery.
Exactly. Quite easy. It's an active cardiac condition, but there's uncontrolled rate lesion. And so I'd postpone, refer to cardiology, and optimize. And if it was urgent, there's many things I could do. So I could, give a beta blocker or amiodarone to try and slow the heart rate, just depending on what the situation is. But as it stands, this is elective and it needs to be controlled. Very good. Now, just given this situation, if she potentially had biliary sepsis, it just changes things slightly. The biliary sepsis could now be causing the tachycardia. So I'd do my best to control the rate, but I have to urgently go ahead regardless of the rate because the solution is getting rid of this biliary sepsis. Just a subtle point there before you move on. So 60-year-old female, laparotomy for incisional hernia repair. The patient has rheumatoid arthritis, and you notice a systolic murmur.
I think, so this is a 60-year-old lady going in for quite a large operation, which I don't anticipate is emergent given the stem.
Yep, no.
Given she's got a systolic murmur, I think it would be worth going in and getting an echo for this lady and delaying the surgery just to further assess what her cardiovascular risk actually is.
That's perfect.
Because that might just change how you manage her on the day.
Because it could actually be a very serious active lesion. Systolic murmur could be AS, it could be HOCM even, and that really matters to me. If when you present this to your consultant, they may then say that for whatever reason, this is unlikely to be severe, but so they would proceed, but it's always best for you as a junior to proceed with caution and, mention this fact. Good. 50-year-old male, inguinal hernia repair with trifascicular block with multiple fainting episodes.
So we have a 50-year-old man for what I'm assuming is an elective inguinal hernia repair.
Sounds good.
So a non-urgent procedure with symptomatic cardiac events. So I would not be proceeding today, and I'd probably be sending him to ED.
Fantastic.
If he's having fainting episodes.
Now, if this patient was trifascicular block with no symptoms at all, what do you reckon?
I might not send him to ED, but I'd be still sending him to a cardiologist.
Fantastic. And what's funny is I get this case with trifascicular block once every year or so, and every single time I call cardiology, they say, yep, no worries at all, just go ahead. But it's not going to stop me. I agree with you. It's not going to stop me calling them because, they could change their guidelines, and I'm not a cardiologist, so absolutely right. So just to clarify now, these are all active cardiac conditions. They have a high mortality, so postpone and refer, and at a junior level, always act cautiously in this setting as well. Let's keep going because I really want to go through this whole guideline just to give you an example of all the situations that will come up, and all of these will come up daily, if not weekly. 78-year-old female, recent echo showing moderate aortic stenosis for cataract surgery. They're unable to walk up a flight of stairs due to arthritis.
So I think moderate aortic stenosis, it would probably still be fit for surgery, but obviously this cataract surgery is probably not super urgent, but it would be impacting her quality of life, so it probably needs to happen at some point.
And if
difficult to assess her.
If you were to follow the guidelines, is it urgent or elective? Emergency or elective? Just to get the format exactly right.
Oh, so it's elective, yeah.
Fantastic. Elective, yep. And did you think that moderate AS is active or non-active cardiac condition?
I'd say that's active.
Yeah, so our guidelines would suggest that it's not an active cardiac condition. It doesn't have the same high mortality that severe symptomatic AS has. And that's why now you can go to the risk level and say, what is the risk of the surgery? Is it low risk, moderate, or high risk surgery?
The surgery would be low risk.
Exactly, and that's everything now. So once it's low risk, do you reckon you can proceed, or do you think you should postpone for more investigation of this patient?
So it's probably okay to proceed.
Absolutely, and it's as easy as that. Again, so just understand how awkward this is when you're starting out. You could have someone with a whole bunch of bad stuff, but that's still okay if if it's not active and they're having such low risk surgery that it's got such a low perioperative morbidity mortality that, you know, it's just not going to cause them a problem. So just to give you confidence in this, you know, I would do this patient maybe 3 times a week, this kind of patient, and you just crack on because they have very little mortality in this procedure. And again, it's backed up by these guidelines as well. I hope that makes sense. This patient isn't great. And if this was any other operation, higher risk operation, I might want to check their mets and investigate. But in this situation, it's low risk, proceed. So elective surgery, no active conditions, low risk equals proceed. So I've just mentioned here, the last patient could be relatively unwell, but stable and unwell. Often these patients have everything: CCF, valve disease, ischemic heart disease, COPD, and a pacemaker, and low risk surgery is still very safe. Let's go to the next one. 60-year-old male, lap collie, unknown exercise tolerance due to back injury, nil past history.
Yeah, so this is an elective surgical procedure.
Yep.
With no that we're aware of from the stem.
Yes.
I would regard this as a moderate risk surgery, and so my next question would be to consider whether he had greater than 4 METs. However, in this case, we're unable to assess it due to back injury.
Yep.
And so I would then probably progress to whether or not further testing would change my management in this case, and it probably would determine whether or not it changed your management. And so you could progress to further testing. Given that he couldn't get on a treadmill for a stress test, I would probably be looking for a stress echo or some other a test not requiring mobility.
Yeah, good. And that's really fair. I like the logic of what you said is exactly right. Now, just to put a bit of a spanner in the works, the fact that this patient has no other risk factors means that many people would make the argument that they are very unlikely to have cardiac disease. And if you were to plug the numbers into the risk calculator, you'd get a very low mortality procedure. That this could be something, this would often be something that people would proceed with. I just wanted to show this, that your logic was absolutely right in the way you went down. And it's by far more important that you showed me the process that you decided your decision. And then it's up to me as the consultant or the surgeon or whatever to then choose to proceed. But you've done the cautious thing, which is exactly right. So that's the right answer. And you've done the right logical thing. And this is where sometimes it's a bit of a gray area. Good on you. Next one. So elective surgery, no active cardiac conditions. And I've just said it's low risk based on the risk calculator, therefore proceed. But, you know, it is definitely not the typical cataract or lumps and bumps operation. So you're right to kind of proceed cautiously and opt for testing if you thought so. Okay, this one, 60-year-old male, total hip replacement, AF of 70, cholesterol, hypertension, obese, stays in bed most days, walks to the lounge to watch TV.
So if you're thinking about this is obviously an elective procedure.
Yes.
So thinking about how urgent it is, like obviously whether we can delay, this guy has quite a few comorbidities, like if he's obese, that's keeping him in bed most days.
And I guess the question you want to ask, just so you proceed through the guideline in a logical fashion, you're right that it's elective. The next one is it an active cardiac, is there any active cardiac condition?
True, yeah. So he's got AF, which seems to be well rate controlled and has high hypertension.
So is it active or non-active?
It's non-active.
Perfect, yep.
Yeah. And then looking at his risk, probably, I'd say this surgery is low risk, but he's probably a high risk candidate given his obesity and his...
Yeah, they talk about this operation being kind of a moderate risk operation. So, and that's okay. It could be moderate or high risk, but as long as it's not low risk, then you go to the next step of what's the next one after? Is it low risk or not? The next question you have.
So then you look at his METs.
Perfect. And what do you want to ask me if I was the patient?
So like how far he can walk, other exercise tolerances has, whether he can walk up a flight of stairs or not, whether he can up around the block.
Fantastic. That's exactly right. So it's not emergency surgery, it's elective. I then check active cardiac conditions. None of that is present. It's not a low risk operation. If the Mets are good, then I would feel like proceeding is reasonable. Often the Mets are poor or unknown because the patient's disease prevents them from moving much. And then I'd go through whether cardiac testing would change the risk for this patient, or cardiac testing would change the management for this patient. So then I'd go through, then I'd go through whether cardiac testing is relevant or not. Now, just realize that after you've gone down to the very pointy end of things, at the bottom of this flowchart, that's most of the time when the consultant will make the decision. So I wouldn't get bogged down too much whether you definitely go for cardiac testing or not. It's just a low evidence level area. So you'll find a certain amount of frustration or maybe even contradiction in what certain hospitals and consultants do versus others. Just appreciate that for what it is. The important thing is that you know the procedure to get to your decision and show you're working, okay? This final one, 80-year-old female, lots and lots of stuff going on, but they're all stable and optimized. That's all important to know. Walks every day, independent ADLs, and what do you want to know?
So for this patient, it's likely an elective THR, so we would proceed. If she doesn't have any active conditions, the risk, albeit in the context of all of these conditions, might increase to mild or moderate. Because they're all stable, it pushes it towards the more mild side. Subsequently, you want to look at the Mets. She walks every day, so I want to quantify how far she walks.
Yep.
If, however, I believe that because of the activity, the reasonable Mets, I think that she doesn't need further testing and she will be able to proceed to theatre quite reasonably.
Fantastic. So you asked the right questions there. You know, what are the Mets for this patient? Because it's not active. Sorry, it's elective operation, no active conditions, and the other stuff is stable and optimized. It's not low risk surgery. What are the Mets? They're 4 Mets. If they can do 4 Mets, then I can proceed with good evidence. And then this final one, I'm just going to go through. 65-year-old female, total knee replacement. Again, a lot of stuff going on and poor exercise tolerance. And they've got a lot of risk factors for ischemic heart disease. Plus, they've also got ischemic heart disease. So if they've got poor exercise tolerance and haven't had the relevant investigations, this would fall under the category of it's elective, no active cardiac conditions, it's not low risk, less than 4 Mets for this patient. So I'm at the bottom of my guideline, at the pointy end of things, has multiple cardiac risk factors. So, really highly likely to have something going on if they haven't already been tested prior to this. And so I might do some cardiac testing or refer for cardiac testing. So that's the guideline as it stands. And again, hopefully, I learned this so late in the piece. I just thought it would be really amazing if, all my registrars knew this at the very start. It would have helped me a lot. If I do need to crack on, then I can do urgent cardiology referrals, optimize disease states, as we mentioned previously, step up my monitoring, and then have post-op HDU, CCU. So imagine you can't do anything better for this patient. You do everything you can. And this is the kind of insight I want my registrars to have as they plan for this high-risk case if it's more urgent. So hopefully I've blown your minds with that one. But now I want to blow your minds a little bit more, because let's look at some other situations. 50-year-old elective inguinal hernia repair. They've got active wheezing for the last week. What do? So because this is active, just like we saw previously, I need to postpone and treat. So whether that's postponing, for a few minutes, for 15 minutes to nebulize, then, that's fine. If they've got chronically bad asthma, that's even treatment resistant, then you could postpone and have the full preventer and asthma action plan type thing going on. But if it was, well-controlled moderate asthma, optimized for a lipoma excision, that's now an elective procedure, no active condition happening, and it's very low risk surgery. So really, regardless, you could proceed. What I'm trying to do now is transition your ACC AHA guidelines. Every anaesthetist really loves morning coffee, not just for cardiac conditions, but for any condition at all. Think about a 30-year-old for an elective open cholecystectomy. with known COPD, multiple exacerbations recently. And, what do you do for this? So this is now an elective operation. It's an active condition, so I'd postpone and treat. Active conditions, again, the expert consensus would suggest that you want to optimize these as best as you can if you've got time to do so. Let's give you the hypothetical. It's now well-controlled COPD after a period of optimization. You see this patient on another future list. They've got a good exercise tolerance. Therefore it's elective surgery, no active conditions, it's not low risk, and greater than 4 METs equals proceed. And what they've done with the research on this is that it's not just for cardiac conditions. Like when you look at the patients, these are patients with lots of diseases, and 4 METs means that overall their body can handle this. So if we use the same algorithm for non-cardiac disease, it still works really well. So I'd encourage you, even though it's not a formal thing, this is something I think a lot of us anaesthetists use just intuitively because it makes a lot of sense, because not everything is just cardiac. So the non-cardiac disease algorithm is exactly the same. Every anaesthetist loves morning coffee. Is it emergency? If so, proceed. If it's an active disease state, whether it's acute asthma, upper respiratory tract infection, COAD, or acute renal failure, you need to refer, optimize, stabilize. If it's low risk and there's no active disease, you can proceed. If it's greater than 4 METs, you can proceed. And then will any kind of testing or intervention change management? Consider that and see what you can do. So my summary for this little section here: have an evidence-based approach to the cardiac patient. Again, these are guidelines that expert consensus has decided upon, better than my opinion or anyone else's opinion, really. Know when to proceed or postpone, and having an approach to any disease state for surgery. So really, every anaesthetist really loves morning coffee is something I can think about a lot for this. I've got a couple of lectures I gave for my part 2 for the specialist exam. So those are the links there, and they're just on the YouTube channel. So part 2 exam tutorials for guidelines. Part 1 is literally the ACC AHA guideline. And then exam tutorials 2, I go through the AF guidelines, dual antiplatelet therapy, as well as a pacemaker consensus, expert consensus summary in anesthesiology. So again, really intensely advanced guidelines, but I feel like they're common enough in tertiary hospitals, and there's no reason, you're all smart people, you're in medicine, there's no reason why you can't learn this really effectively. So those 2 guidelines. You can find them on the ABCs of Anesthesia YouTube channel. Someone had a really good question just in the chat about, you say you've got the patient in the bay, they want to have the surgery, the surgeon wants the surgery to go ahead. That is a tough decision. It'll again have a lot of discussion and nuance about it. I try to not take a lot of these decisions on my own. There's a very good principle of sharing the decision making / sharing the blame. Okay, so I get someone who's really risky for whatever reason, isn't optimized, or something's suboptimal has happened. I, matter of fact, tell the surgeon the risks of this. I tell the patient the increased risk of this and what we could do to optimize it. And then say, look, this is a higher risk. What do you want to do? I might even suggest that I would want to delay this to optimize the patient. And some patients will want to go ahead regardless, or they may not be, they may not be able to be optimized, non-compliance with medications or treatment plans or whatever. There's definitely a gray area here, and I try not to take the burden of that decision on myself and try to do an informed consent process, because that's part of our the ethics of Australian informed consent and autonomous decision making. If something is ridiculously high risk, then I'd be far more persistent about that. But the good thing is a lot of this won't be in your hands. You just refer up to your boss, because you won't be making these decisions right away. It's better that you're able to flag these and have an intelligent discussion about them.
I had a thought earlier about a patient who's come in, they've got a murmur, no previously not known about, but for emergency situations, would doing a bedside echo sort of change things in terms of not sending them away?
Yeah,
or stratifying their risk better?
Yeah, so when I think about that, I think, what is the murmur? And often if it's a systolic murmur, it's either going to be mitral regurg, which is very well tolerated under anesthesia, or it's going to be the bad stuff, HOCM or aortic stenosis. If it was, an echo would help me differentiate that if I couldn't do it clinically, and I might slightly change my management plan. But realistically speaking, a lot of people might not have an echo probe, they might not have the experience with echo, and in that case, I would crack on, but I'd imagine that this is the worst case scenario. So if this was severe aortic stenosis, if this was a systolic murmur, I'd say this could be severe aortic stenosis. I've got to crack on anyway. Art line, gentle induction, keep my MAP high, and keep my heart rate low and my preload up. That's how I'd approach that. So yeah, sometimes you just have to make the best with the situation you have. But an echo, more information almost always is better than less information. So I'd agree that I'd like an echo. If I couldn't have an echo, it wouldn't change things too much if I had to crack on.